Hello, everyone, and welcome to this webinar. We have, I can see here, 29 participants, and we expect that this will grow. We have, last week, we saw that many people joined slowly as we progressed. This week is a bit low on the attendance, but hopefully it will grow as we move. On behalf of Stop TB Partnership and the ETTI Working Group, I welcome all of you to this webinar. This is the fourth one in the series, the series on the fourth one of the series under infection control. You can find the previous 3 webinars on our website, the Stop TB website, and also the ETTI website, if you want to go back to them. So this is the fourth one. Also, whatever will be discussed here will be, as well as the presentation, will be uploaded on the website. We have here today a topic which is a subset of this whole airborne infection. If you remember, we did a number of them, different topics. We did administrative control. We did, of course, the face masks, masks and respirator. We did so last time also you heard 2 country experiences which were interesting on how they are dealing with their issues there. So this time, as you all had also mentioned in some of the chat in the previous webinars, this time the focus is on environmental controls for airborne infection, with a focus, of course, on natural ventilation, but also other kinds of ventilation. So we will have here Paul Jensen, who will do the presentation, and then after that we will take your questions, and there will be a question answer after that. I will be here for 1 hour, and then I will leave, and Viorel Sultan from Stop TB will take over to do the facilitation of the question and answer. And Carrie Tudor is there from the ETTI working group, as well as other members of the ETTI working group who will participate in the discussion as well. So with that, and let me introduce myself again for those who may not know me. I am Suvanand Sahu. I work as Deputy Executive Director in the Stop TB Partnership here in Geneva. So welcome, and over to Paul. Paul, if you're ready, the floor is yours.
Good morning, good afternoon, good evening. So as Sahu mentioned, I'm going to talk about environmental controls with a focus on natural ventilation. And we can't forget about the hierarchy of airborne infection prevention and control. And that's the managerial and administrative controls, environmental, and PPE. And when we're thinking of applying environmental controls, we may do something for the worker, something for the patient, something for the entire facility. So environmental controls cannot be separated from the administrative controls. Why? Because we need the policies and practices in place to support the environmental controls. So first off, we need to think about safety. And for those who've seen this video before, I apologize, but it really takes gets the message. Where here it's a renovation site, or it could even be a new construction site. And what do you have? You have a lot of mess. You have a lot of activity. And here's somebody walking by carrying something heavy. And what does he do? He changes arms to protect his back. But is he paying attention to his surroundings? And I guess not. So anyway, what we want to do is talk about environmental controls. And you saw this slide also 2 weeks ago, and the rest will not be repeats, I promise. And what do we think of first in terms of environmental controls? we really need to think about the facility, the layout, the administrative controls. And then based on risk, we will decide, okay, what types of environmental controls do we need? In this case of the presentation today, we're going to talk about ventilation. Obviously, ventilation is not the only environmental control, but it's a topic for today. So what are the goals of implementing ventilation? The goals are to either dilute or remove the contaminants in the air, whether it's TB or coronavirus or something else. And also, in some cases, you want to contain it, prevent it from spreading through the facility, or you want a protective environment where you're preventing whatever is airborne from getting into a location. And there are different types of ventilation. There's local ventilation, we'll describe that, general or dilution ventilation, and then there's piston or plug flow ventilation. And different technologies or ways of doing it. We're going to talk about natural ventilation today. We'll briefly talk about mechanical. We'll talk about mixed mode. And then next week, we'll be talking about the mechanical ventilation and also room air cleaners with Grigory Volchenkov and myself. What does local mean? It means control at the source. The most effective method for ventilation is really to control at the source. So you're preventing it from getting into the environment. And it's used often for laboratory procedures, for sputum collection. And what do you see here? Obviously, it's a laboratory. And the piece of equipment next to the window is a Class 2, B2 biological safety cabinet. And what is that designed to do? It's a type of local ventilation. The idea is whatever you're working on inside the cabinet stays inside the cabinet in a clean environment. But let's take a look at this short video. And what the person here has in his hand is a smoke tube, a way to visualize airflow. So you're working in the cabinet. Is that the way it's supposed to work? Obviously not. So when we're talking about any kind of ventilation, in this case it's local ventilation, we want to make sure it's working properly. So we need the policies and practices in place to assure that that happens. What is this? It's not a giant telephone booth. It's a sputum collection booth. So air would go in the bottom, up across the patient, and then out this fan to the out of doors. So it's containing the aerosol in the smallest volume possible. Now, I took this slide from the guidelines on airborne infection control from India because it's got a nice summary of mechanical, natural, and hybrid. And it talks about the advantages and disadvantages. Mechanical ventilation, if done properly, and you'll hear me say that for everything here, if done properly, is suitable for all climates and weather. It's more controllable, and the occupants generally have limited control to do something to the ventilation system that might not make it work properly. Disadvantages, it could be expensive to install. And if it fails, then you may have a situation that's less safe than what you had before. Natural ventilation is suitable for warm or temperate climates. It's a lower capital cost, lower operational costs, lower maintenance costs, but there is maintenance involved. What do you have to do? You have to make sure that the windows work, that the doors work, that the vents are clear, but there are a lot of disadvantages as well. It's affected by outdoor climate, outdoor pollution. It may be difficult to retrofit a building, so you have to plan and design in advance. And in some cases, the comfort level inside may not be adequate. In hybrid mixed mode, hybrid or mixed mode, means that you're adding mechanical and natural, so that when natural alone cannot handle the situation to the level that you need it, you can use mechanical. And it's suitable for most climates. It can be energy saving because you can use natural ventilation instead of the mechanical at times, but it may be more costly or more difficult to design if you don't do it in advance. So I just put this table in here so you can see all three at the same time and use it as a reference in the handout. So when we talk about environmental control issues, what do we want? We want to make sure that the situation is sustainable, that it's well designed, that we think about operation and maintenance from the design stage, not just after something's installed and you've cut the ribbon. When we talk about ventilation issues, yes, we want dilution removal, we want containment, and we also want comfort. We need temperature that's comfortable, we need humidity that's comfortable, and we need a noise level that's comfortable. If somebody is lying in bed and hears this grinding of a fan all day, all night, he or she might do something to make that system quiet. And what could that be? It could be disconnected, throw something in the fan so it stops. There are many things that patients and staff do to make ventilation systems not work. So let's go through a definition here. What is ventilation? And it's multiple guess. Is ventilation open windows? Is it fans? Is it air conditioning? Is it the #1 airborne infection control measure? All the above or none of the above? Well, this is sort of a trick question because open windows could be part of natural ventilation if it's designed properly. Fans, that's sort of a generic word. Fans could be something that will push or pull air. It could be something to just mix air. So it may be part of ventilation. Air conditioning. If you have just a split unit, these units on the wall that help cool the air in the summertime, that's really not ventilation. That's just cooling the air and mixing the air. But if you have a ventilation system, the system may have air conditioning in it, so it pulls air out, may exhaust it directly outside, or it may recirculate through filters, and then sends it back into the building. That type of air conditioning is part of a ventilation system, and that would be ventilation. And we know for sure it's not the #1 airborne infection control measure. Why? Because administrative controls are. So when we talk about ventilation, next time you or your kids have a birthday, and we know Mohammed's son had a birthday yesterday and the other child has one in a few days. So I challenge him and all of you to take a look at the birthday candles. And before they're blown out, try to suck the flame out. And don't burn your lips or anything, but you have to get super, super, super close to that flame to be able to suck that flame out. So when we're talking about ventilation, how efficient do you think exhaust only is? Well, exhaust only ventilation might be effective if you're super close to the source or to the coughing patient or sneezing patient or the point of generation. So when we talk about ventilation, we need to get the air to move. We need to push and or pull particles or vapors from the air. So we want to push particles, ideally, towards the exhaust so the exhaust can pull those particles out of the room. And ideally in a controlled manner. So now another multiple guess question. What factor is most likely to result in the failure of an environmental control? Well, we talked about comfort. Comfort, comfort. All the above. So this was another trick question, except it does have one absolute answer, and that absolute answer is #4, all of the above. Because if the patients and staff are not comfortable, the chances of the system working and being effective is not very high. So what affects comfort? Well, there are many things that influence thermal comfort. Includes activity, clothing. People at home might be used to wearing a sweater, but when they're in a healthcare facility and they're in bed, they won't be wearing warmer clothes. So maybe they need an extra blanket, or maybe they're expecting, the facility to be cooled in the summertime, even though their home is not. And there are cultural differences. There's radiant temperature, so if the sun is shining on your window, you get a lot of heat coming into the room. And airspeed is very important. Why? Why? Because when you get air over top of your skin, it gives you a feeling. It may not actually change your temperature much, but it gives you the feeling of cooling. So in the summertime, it increases the evaporative cooling. So what about summer versus winter? Well, summertime, you might find higher velocity of air across your body is good because it helps with the cooling effect. But wintertime, you do not want high velocities of air going across your body. Why? Because it gives you a feeling of cooling, and it's a situation where you really want heat. So summertime, you can tolerate higher velocities than wintertime. I've used the term general or dilution ventilation. So what is it? Well, it's made on the premise that you have equal distribution of particles through a room. And then you push air into the room and you pull air from the room. And ideally, you'll get some particles coming out over time. And in this case, this is a exponential decay, where on the bottom axis, you see elapsed time. On the vertical axis, you see concentration. It could be particles per cubic meter, any really any unit. And the lines are set for different air changes per hour. What we also have here is a room in which there's no further generation. So the patient may have left the room where the procedure is no longer being done. So if we take a look at the 1 hour mark, 1 air change per hour will leave roughly 37% of the particles, or remove will leave, 37% of the particles. 2 air changes per hour will leave about 14% of the particles. When you double it again, 4 air changes per hour will leave about 2% of the particles. If you double again to 8 air changes per hour, you'll see it's much less than 1 air change, much less than 1% of the particles are left. So when somebody talks about 6 to 12 air changes per hour, they're using that number because that's usually from the cost benefit standpoint, the maximum. So how much additional benefit do you get to go from 6 to 12? Well, there's a small amount, but the advantage of designing for 12 is that most likely you'll get at least 6, which is good. So what happens in reality? What you see here in the center is, here's a patient that's coughing. So you get not necessarily even distribution, but you get a clump of particles. And then what happens to those particles? They spread through the room, and then some of the particles come out. So it's not immediate, it'll be some kind of a decay. And this is also from the Indian Airborne Infection Control Guidelines, but it's very similar to most other guidelines too. If we take a look at the bottom row first, high-risk settings and waiting areas, ART centers and whatnot, they recommend at least 12 air changes per hour, as well as 80 to 160 liters per second per patient. In inpatient departments, outpatient departments, registration areas, they recommend at least 6. So these are reasonable recommendations. And you have to take a look at the WHO guidelines, at your regional guidelines, your country guidelines, to see what's appropriate for you. This is a table from the CDC 2005 guidelines, but what does 6 air changes per hour mean? It means that you'll have a 99% reduction in 46 minutes in a perfectly mixed room and no further generation or no patients in the room. Or if you go to 12 air changes per hour, it'd be 23 minutes. If you want a higher reduction, then we're talking about longer periods of time. What is piston or plug flow? This is kind of a new slide for me, but what it's showing here on the left is air is moving into the room The arrows on the right is air moving out of the room. So again, here's the patient coughing. What happens? In theory, it just slowly moves across the room and it moves out. What happens in reality? The patient's coughing, and not only does it move across the room, but it also diffuses through the room. Not through the whole room, but just in the direction in which the air is moving. In this case, it's left to right. You can see that we aren't increasing the number of particles, we're just increasing the distance between particles as it goes across the room and out. And what does that remind you of? It reminds me of open windows, open doors, good cross ventilation. So what happens to these people? Well, over time, instead of this being mixed immediately, the organisms are in a clump, you could say, and this guy has the potential for breathing a lot. This nurse has a potential for breathing a lot. So instead of equal risk for everybody, it's higher risk for a few. And I came across this quotation from Erasmus Darwin, who is Charles Darwin's grandfather, from 1760, and I'll just read it. It says, "Ye men of Nottingham, listen to me. Air becomes unwholesome in a few hours if the windows are shut. Open those of your sleeping rooms whenever you quit them to go to your workshops. Keep the windows of your workshops open whenever the weather is not insupportably cold. If you would not bring infection and disease upon yourselves and to your wives and little ones, change the air you breathe. Change it many times a day by opening your windows." So what does Dr. Darwin say? He's saying use natural ventilation when possible, but he also admits some limitations. So now we're going to just switch and only talk about natural ventilation. So here's a guideline for 2019 from WHO on natural ventilation for infection control for healthcare settings. And the #1 recommendation basically says that to prevent or reduce airborne infections, ventilation is needed. It doesn't say mechanical, it doesn't say natural, it just says with ventilation, the risk of airborne infections is reduced. Recommendation 2 is broken into 2 parts. It actually gives some air flow rates, so 160 liters per second for airborne precaution rooms, 60 liters per second per patient for general wards and outpatient departments, and a smaller amount per cubic meter for corridors and other transit spaces. Now, what happens in corridors? Quite often they become waiting rooms. So you might need higher levels of ventilation. So when you take a look at the Indian guidelines, the WHO guidelines, the US guidelines, they all use similar rates of airflow. They may be in different units. Based on the size of the room, you may have something in terms of air changes per hour. You might have something in terms of liters per second, cubic feet per minute, cubic meters per hour. And you can always do the conversions to see how close the numbers actually are. But the most important recommendation is the second part of the #2 recommendation. And that's telling people that when designing such facilities, remember that according to the local climatic conditions, there may not be enough airflow at all times to provide natural ventilation. And then if that's the case, then alternative ventilation systems such as a hybrid natural ventilation system should be used. And we'll talk about that in detail in a minute. So what is natural ventilation? It's supply and removal of air through an indoor space by natural means. And we're going to talk about wind-driven or horizontal natural ventilation and stack-driven or vertical natural ventilation. So wind-driven, again, is horizontal. Stack is based on what? Buoyancy. So it'd be your vertical natural ventilation. So when we're talking about wind-driven or horizontal, the wind is unpredictable, both in speed and direction, And the other thing that's not totally predictable is outside temperature. You may go from comfortable to cold, comfortable to hot, and how do you deal with that inside the building? When we're talking about building design, the cheapest means of natural ventilation is cross ventilation, but you need to have openings on opposing or opposite walls so that you get good cross ventilation. What about air quality? If you're in a very polluted area, do you want open windows at street level? Maybe not. And if not designed properly, and this is the window design mainly, you may create strong drafts and discomfort. And what are patients going to do if they're not comfortable, or staff if they're not comfortable? They may be closing the openings that you need for natural ventilation. So here's an old picture, and from what country is this? This is actually an old pediatric TB sanatorium in the US. So what did they do? They put the kids out in this reading room. Some are paying attention, I think some are sleeping, but they're wrapped up nice and warm while the nurse reads them a story. So what have they done here? They've created a well-ventilated place. You've got radiators all around the walls, but they give blankets and hats to the kids to keep them warm. There is a general rule of thumb, and you've probably read about this somewhere, is that if you take roughly 65% of the wind speed and multiply by the opening of the window or the door or whatever is open on the one side and divide by the room volume, it gives you an estimate for air changes per hour. But let's talk about that a little bit further because there's more to it than that. So here's a consultation room. What do you see on the right? A window. Well, a funny window. It looks like part of it has shutters and part of it has glass. Well, let's just assume that this is the open part. So air can go in and out this window on the right. What is this? This is a grill under the door. So which do we use? Do we use this opening or both for a gross estimate? Well, in here it says the smallest opening because that's the restriction, or that's where the most resistance will be and the least amount of air going through it. So even though you have a huge opening on one side, if you don't have a large enough opening on the other side of a room or a building, you're not going to get much airflow. And in this case, the wind is blowing from left to right. It could be blowing from right to left. Even if it's blowing from right to left, the limiting factor is the small diffuser or grill at the bottom of the door. This is a picture from the 1999 WHO guidelines for TB infection control. And it's kind of interesting. It shows air moving from left to right across this long patient area. Well, is it always going to be left to right? Or is it going to be from right to left? Or is it going to be back and forth? It could be anywhere because we know air does not follow the arrows. So here's an interesting facility. You can see a lot of open windows here, an outside corridor. And let's take a look inside. What do you see here? You've got lots of open windows. The patients are actually outside right now. They have common toilets in the back. And what's at the top of this ceiling? Well, it used to be an open ridge vent. So you could always have air coming in the top, up and around. But to make it nicer, when it was renovated, they put glass in the top here. So no air is coming in the top. They put a nice ceiling here, so no air is going out the top. So they do have some cross ventilation, but they basically made the building less efficient. So in no wind conditions, there's very little air exchange, where if there had been, if this building had been maintained as designed, you'd still have some stack effect or some air movement. So let's take a look at a facility. This is from the Church of Scotland Hospital in Tugela Ferry. And they basically turned a ward with an open veranda into a ward plus patients in this veranda. And here are the patients in that veranda. So it's one large facility. And what do you see up here? Well, somebody said that, oh, well, these patients need some privacy, so they installed all these curtain rods. And what do curtain rods do? Well, the ladies here and the gentlemen in the male ward were all upset because what's over here? A TV. Now they can't see the television very well. Plus, what happens if you hang curtains? What's going to happen to the air movement? Well, you're not going to get as good an air movement with curtains. So what we're doing here, this is just a vanometer. We're just showing people, how important it is to have windows open on both sides. So if you ever want to see how important cross ventilation is, close the windows on one side, and with a vanometer or a piece of yarn or silk, hold it there and see what happens to the air movement. It probably just goes back and forth and back and forth. Where when you open the windows on the opposite side, you get a lot more airflow. And in this hospital, what they did was they didn't think they had enough natural ventilation, so they did a hybrid system. They added mechanical ventilation. So these are exhaust fans, these three blue things. This is a plenum that goes across the length of the facility. And we're trying to measure ventilation. How much air goes through that one diffuser? Well, everybody can read the meter. It says 0.00, or very little airflow, but we could hear the ventilator. Well, long story short, the wiring of the ventilator was set backwards. So the fan was moving backwards, which means it's very, very inefficient, and almost no air was moving. So even though you've tried to supplement things and do it properly, things can be done improperly, which is why it's important, even with natural ventilation or hybrid, to make sure you test the system before you accept the system. So here's the facility with no patients. And what we're doing is we're releasing through these two bottles some CO2 in the room. And we had sensors around the room. And here's Tony Mall. This is just carbon dioxide coming out. But we were putting enough in the room to measure, not enough to injure us. Then we'd shut off the CO2. We allow it to reach equilibrium. And then we test it with the window, with everything off, with the ventilation system only, and then with the windows open. And what we found was with the windows closed and ventilation off, very little air exchange. So it was a relatively tight building. Then we had windows closed and ventilation on. We measured about 16 air changes per hour. And with all the windows open and mixing fans, not the exhaust ventilation, but mixing fans were on, we had about 67 air changes per hour. And what does this mean? It means that that one point in time when we did the test, we had low air exchange with the windows closed. It was okay when the ventilation was on, and we had high when the windows were open and the mixing fans were on. But again, it's only under these conditions. So we want to make sure that we understand that if you try to measure, it's only for that one point in time. And when you do the calculation, it's not 7.4371 air changes per hour, it's 7-ish. So if your guidelines is greater than 6, I would say it's okay. So don't put too much emphasis on absolute numbers. Let's talk about stack-driven or vertical natural ventilation. It does not rely on wind. It relies on naturally occurring force. That force could be, heat from us, heat from equipment. It can be relatively stable relative to wind-driven natural ventilation. So here's an opening in the wall. And we were told, okay, this goes to a channel or a duct that goes up through the roof. So what is this? This is a vertical natural ventilation duct. How much air goes through that? Well, we had a piece of paper and it was sucked onto that grill. So this is wintertime in Russia. And what did we have? We had almost 6 air changes per hour going through that little opening because there's so much heat in the patient room that the heat was being lost up through this channel. But losing heat can be a good thing as long as you don't lose too much. As long as the patients can stay comfortable, then what that heat does, it helps force air out of the room. So we have to make sure we have a temperature differential inside to outside. Warmer inside than outside, you'll get airflow from the room to the environment. So how well will this type of ventilation work in the summertime? Well, summertime, the temperature inside and outside will probably be relatively close. So you're not going to have much forcing function for vertical natural ventilation. And most people have seen a whirly bird. What does a whirly bird do? 2 things. When there's not enough wind to make it rotate or whirl, then it acts simply as vertical or stack-driven natural ventilation. When there's some wind and this piece of metal on top rotates, it creates a negative pressure and can pull air out of the room or wherever it's connected. So if we just take a look at one particular whirly bird, if the wind is 15 kilometers an hour, which is about 9 miles per hour, the diameter is 30 centimeters or about a foot, then the airflow rate is about 1,500 cubic meters per hour. Is that a lot or a little? Well, the answer is it depends. So let's do a calculation. Let's just say we have a 3 by 5 by 2.7 meter room, which is about 40 cubic meters. If we calculate air changes per hour, we've got airflow rate divided by room volume, or 37 air changes per hour. Is that a lot or a little? It's phenomenal. So what we want to do is see, okay, where can we use natural ventilation? This picture was originally a depiction of a large multi-bed ward. And they had windows on either side and had some cross ventilation. For privacy reasons, they made them into a bunch of smaller rooms. So what do you have here on the right? You have air coming in and out of the window. If the door is open, in and out of the door. And how much air exchange is there by this bed? Very little. By this bed, probably a lot. How about in this room? You only have the window, so there's going to be less air exchange in the bed, and even less by the second bed. So we want to try to avoid a situation like this. And if you do have a situation like that and perhaps consider whirlybirds, well, then you'll get a little bit of the air that's coming in, move across a room, and hopefully go out through that whirlybird. If you take a look at the WHO 2009 natural ventilation guidelines, you'll see there are a lot of different types of natural ventilation systems. The most common is the one here on the left with the cross flow. There's some others that really have to be designed in the building, not retrofitted, where you have air scoops or stacks or some way to enhance the air movement. Then you have some hybrid systems, and hybrid just means that you've got natural ventilation with some mechanical ventilation. That mechanical ventilation will be used when perhaps the wind isn't strong enough or the temperature differential isn't enough to get sufficient air change. I'm not going to go into each of these individual designs, but if you take a look at the book, there's some drawings on how to do it. How well does natural ventilation work? Well, this is a picture of a hospital ward, TB ward, from Peru. And Rod Escom did a bunch of CO2 experiments. What he found in this top one with these large windows, nice spacing between beds, was on this one particular date and time, he found about 18 air changes per hour. Then they had a ward outside of this that had windows on 3 sides, and there it measured 32 air changes per hour. So yes, as long as you can keep the patients and staff comfortable, you can have a lot of air exchange. But what happens when you close the windows when it gets cold? Then you're approaching very little air exchange. How much air goes through curtains? Well, what they've done here with the curtains is they provided privacy, perhaps some shading from the sun, but they've also stopped air from moving through the room. How do we deal with sun, rain, and wind? Take a look at this facility. Now, the sun, luckily they have some bushes here for the low sun, but when the sun is up, you can get a lot of radiant heat on the windows. What happens if the wind is blowing? Well, you can get a lot of air going in, but what if it's raining and windy? Well, for sure, the rain is going to go inside the building, so what will they naturally do? They'll naturally close the windows. So what do we need to think about in the design stage? Well, maybe we need the overhang simply to be a little bit bigger. It'll provide additional shading, and it'll keep the water from coming into a building when it's raining. Now, everybody asks me about how do you measure natural ventilation? Well, I'm going to go through a few steps to discuss it. Here's a vanometer. At this one point in time, at this one location in the window, you can see that the air is moving into the room at a little less than 1 meter per second. So how would you calculate airflow rate? Well, airflow rate is velocity times area. So if you're measuring velocity in meters per second, you multiply that by the area or square meters of the opening, and what? We need to convert cubic meters per second to cubic meters per hour. So you can measure air velocity and direction with something as simple as a vanometer, because that vane tells you which way the air is moving. Or you can use something like this. This is a hot wire anemometer, or an expensive electronic velocity meter. And with natural ventilation, there's so much variation that even though the precision here could be 5 to 10%, so it's moving much greater than 5 or 10%. So the value isn't is meaningful. And then on the far right are what? Smoke tubes. So you can see which way is the air moving. So you can use either sets of these. And let's talk about windows. We'll start with the upper left corner. A double hung window. What does that mean? That means you've got the top window can move down, the bottom window can move up. But what is the openable space, or the effective opening in terms of natural ventilation? It's really just a little bit less than half of the area of the glass. Why? Because you can either slide the bottom one up or the top one down, but with the frame and all, you've got less than a 50% opening. Well, some people say, oh, well, we've got double windows. Well, that's true. You've got double windows, so you have roughly double the opening of this, but it's not the total area of the window. You have sliders, moving left and right, same as a double hung, except for it's sideways. You can see a hopper. This one slides out. You may have another one that rotates up, but the effective opening is much less than the glass. Or a casement window that swings out is much less than the glass. It depends on how far open the actual window is. And then this is a window similar to what you saw before in one of the photographs, but it's a big glass area, but the openings are only as big as each of these panels move to the center. And if only one panel is open, that's half of the possible openable area. And if they're both closed, you've got zero air moving through that window. And when we talk about windows and this long of a talk, it's now 10 minutes before 10. I have a few more slides to go, but let's just have a little snack. Somebody sent me this video after our golden retriever passed away, and I just thought it was neat because our golden retriever was a chow hound. So here's a race. Oh, there are 2 dogs there. Who's going to win? And what's the prize? Well, I think the Goldens won for sure. Anyway, let's get back to reality. How do we measure air velocity? Do we just put the meter at the center of the opening? No. What we have to think about is what actually happens. So here's a window. To the right is the outside of the building. To the left is the inside. So you might find at the top, air is going out. Why? Because maybe it's warmer inside than outside, so the warm air is going out. And then it gets a little bit lower and lower and lower. And at some point, it's going to start to come in, because you can't only have air going out unless you have good cross ventilation. So where do we measure? Well, I'm exaggerating the number of points, but we need to measure a lot of points so that we can understand, okay, what is going in and what is going out of the room. And we need to have some kind of convention. You could say negative is out and positive is in, or vice versa. It doesn't matter as long as you know what is going in and what is going out. So we would calculate the velocity in times the area in for each one of those points, sum it up, and that would be the total flow rate in. And we do the same thing for velocity times area out, and sum it up. And they should be close to each other. It won't be exact. It could be plus or minus 10 to 20%, but that's probably good. If you only have one window in a room for natural ventilation, do not even try to calculate air changes per hour, because it's a very meaningful calculation. If the room has cross ventilation, sum up all the ins and outs and see if the in and the out differ by more than 20%. If they don't differ by more than 20% at that one point in time, that's probably a reasonable airflow rate to use to calculate air changes per hour. If it's more than 20% difference, stop. Don't even try to calculate air changes per hour. And air changes per hour is basically the airflow rate divided by the volume of the room. So the airflow rate would be cubic meters per hour, and the volume of the room would be cubic meters. So what are some of the limitations of measurements and calculations? The results of the air changes per hour calculations are only as accurate as the measurements taken. So if you have a lot of gusting of the wind, then it's not going to be very meaningful. But what you can say is, if I see the vane in the vanometer or the smoke moving in or out fast, I would say, okay, I've got some air exchange, as long as it's cross ventilation. And the results are only representative at that one moment in time. The results will differ, possibly 1 minute, 1 hour, 1 day, 1 month, 1 year from the time originally taken. So it's not that you will always have, greater than 20 air changes per hour, whatever number you calculated. So to kind of summarize what we've talked about now is ventilation is needed for healthcare facilities. We know that natural ventilation needs to be designed into the healthcare facility. We know that natural ventilation may be very effective if administrative controls are in place. So I was in a facility a number of years ago and went into the waiting area, and all the windows were closed. Why? Well, the one person who was in charge of making sure the windows were open every day was on vacation. So no one had the responsibility to fill in for that person. So nobody opened the windows. So that waiting area had almost no ventilation. How effective is natural ventilation? We know it's dependent on the microenvironment. And I didn't say just microclimate. The climate, temperature, and radiant heat and everything is one issue, but microclimate also includes noise, are you on a busy street, pollution, and other aspects. So to kind of summarize what we've talked about today was we talked about natural ventilation, and this is from the 2009 WHO Natural Ventilation Guidelines, but they broke the climate into 4 zones: hot and humid, hot and dry, moderate and cold, and gave some general guidance of how effective would different types of natural ventilation be, how effective would mixed mode or hybrid ventilation be with the natural ventilation. And then next week, Grigori and I will be talking about mechanical ventilation. So I'm not going to go into any more of the mechanical ventilation. So on that count, when we're talking about natural ventilation, what we see 90 to 95% of the time is cross ventilation. And this picture is a little bit distorted because it's a panorama, so the room is actually rectangular. But what do you see here? You see lots of open windows on either side, much more than 10% of the square of the room. And that's the rule of thumb, is you want at least 10% of the square of the room on opposing walls. If these shutters are closed at night, how much natural ventilation do they have? Almost zero. So on that note, I just want to give you a little advertisement for Stop TB Partnership and the NTB Transmission Initiative Working Group. And if you go to our website here, we have some resources that are available for you in multiple languages. There's one on respiratory protection, respirator fit testing, one on upper room germicidal UV, which is also called UVGI, and some people call it UVC. So don't get confused with the nomenclature, but it's sort of the basics of upper room UV. We have the schedule on this slide for the next 4 webinars. As I mentioned, next week, Grigori Volchenkov and I will be talking about the ins and outs of mechanical ventilation and room air cleaners. The 21st, Ed Nardell and Richard Vincent will be talking about applications of GUV systems or UV systems for airborne infection prevention and control. The 28th, Dr. Serene from the National Institute of TB and Lung Disease will be talking about implementation of airborne IPC. And on the 4th of August, Isabel Ochoa, an architect from Peru, will be talking about airborne IPC lessons learned from Peru, patient flow and infrastructure changes in the era of COVID-19. And you'll see, and please go to the websites and take a look at these future topics. And if there's a topic here that you think we should prioritize and talk about and add to our list, let us know. If we need to repeat something or explain something differently, let us know. So we want feedback on topics for administrative controls. There's 2 slides for environmental controls and 1 for PPE. And Sahu mentioned the ones that we've already done. I put a line through them to say that we've already done it, but it's still on the list because there may be other things. In this case of respiratory protection, are there things that we need to talk about that have come up since the first talk? So on that note, I thank you very much. I'll go ahead and stop sharing and turn this back to Stop TB Partnership.
Thank you, Paul. Thank you for going through the presentation. Today, we didn't have a busy chat area. Usually we have people commenting and questions there, but I didn't see many. So I think this is the time for question and answer. I will have to leave now, and Viorel from Stop TB will take over. Viorel, if you are there, if you can facilitate this discussion. Meanwhile, those who want to speak, either write in the chat box or raise your hand or unmute and speak.
Yes, thank you, Saho. Good afternoon, everyone. I'm with the Stop TB. I'm leading a team here, which is called Country and Community Support for Impact. So I will take over from Saho and will manage the session, the Q&A session. I invite you to raise your hands or write in the chat room. So I see a hand here, Daisy. Please unmute yourself and
yeah, my question is that for an academic building. Academic building means in nursing students of 60 to 70 sitting in a classroom. For them, which type of ventilation will be good? Cross ventilation or stack ventilation?
Okay, very, very good question, and Daisy. And there, you raise up an issue that I did not mention before, and this is true for any type of natural ventilation, or correction, any type of environmental control, and that's crowding. You know, in an academic building, quite often you'll have one person sitting next to another. And it doesn't
Yes.
matter if it's TB or coronavirus or measles or anything else. You could have 100 air changes per hour in ventilation, but it will not stop transmission from person to person. So, you know, what we need to think about is what can we do in that situation? Well, we could do a combination of the two.
I think we should be going for a mechanical ventilation, like pressure system type of thing or something.
Yeah, well, yeah. I'm going to get to that. And what we want to think about is, you know, what is feasible. Well, first off, you know, is there a way to decompress? You know, in in today's environment with coronavirus, then we want to have some administrative controls in place, such as masks and maybe you know, limiting the number of people that we have in a classroom. From the standpoint of ventilation, what part of India are you from?
I'm from Delhi.
From Delhi, okay. You know, if we just did natural ventilation in Delhi, and many other cities, I'm just saying Delhi because that's where you're from. Right now, you've got relatively clean air. And once industry and everything else goes full speed ahead again, then there'll be relatively polluted air. The same thing with like Lima, Peru, places in China, around the world, there are issues with pollution. So we can't always rely on natural ventilation for that type of environment. You know, Delhi and other areas get very hot. So we can't use the stack ventilation very well in the summertime because there's not going to be much temperature differential. You could use some cross ventilation, but in many academic campuses, there's not much room between buildings to get efficient cross ventilation. So what I'm getting at is, you know, I think your premise is correct. That you might find that the ideal situation here, from the ventilation point, would be some type of mechanical ventilation. But you'll hear next week there are issues with mechanical ventilation. It's more expensive maintenance. There's a lot involved in design and making sure that the air down where the students are sitting is clean. You know, so you could have a poorly designed mechanical ventilation system that you know, cleans the air in the top part of the room, but doesn't get down to where it's occupied. And then another alternative, and you'll hear about this in 2 weeks in more detail, is the use of ultraviolet germicidal irradiation. And if you have good air mixing, and you have UV, and you have some type of ventilation for fresh air to lower the CO2 levels, then you know, you might have a second alternative. Does that help you at all? It's not a definitive answer. Okay, certainly.
Thank you, Daisy. Thank you, Paul. I see in the chat Fernando Sanchez already commented that it's a very good presentation. It will help a lot translating theory to operational and pragmatic routine. I also see another hand. Peter, if you unmute yourself. We don't hear you. Peter, it sounds that your mic doesn't work. Okay. I guess you may wish to reconnect. Maybe.
Okay.
Hello.
Yes,
Yeah.
now it's working. Please go ahead.
Hello, can you hear me?
Loud
Yes.
and clear.
Hello.
Yes.
Peter, I hear you loud and clear.
Hello.
Okay, Peter, I think your microphone is working now, but your speaker is not.
So in the meantime, when Peter
Sorry,
yes,
can
please.
you hear me?
Yes, we hear you very well. Okay.
Okay, Grigory Volchenkov raises a very good question, and that's what about maximizing natural ventilation in cold climates? And there are a couple facilities that I've seen in South Africa. One's actually in Brooklyn Chest Hospital.
Hello.
Okay, Peter, can you hear us? No. Okay. Anyway, and what they have there is they have a series of individual buildings. Each building has a setup for 2 patients, and they're separate facilities for each patient. Each patient will have a room for a bed. They'll have a room, within there. There'll be a wall. The other side will be a ablution facility or toilet facility, and then openings on the other side. So it's designed for natural ventilation, so air can come in one side, out the other, and also it has ridge vents and soffit vents. So it's actually well designed for natural ventilation. Now, their definition of cold will be a little different than Grigory's definition of cold. But what they have there is they have radiant heat from the floor. So they've got coils going through the floor to warm the floor so that the patient, when he or she is on the floor, can feel a little bit of warmth. And then that warmth will move from the floor to the air. And then convection will move that air up and out the soffit vents in the ceiling vent. So it's a way of having some air exchange with the windows closed and just relying on vertical or stack ventilation. Now, if we talk about a cold environment where it's minus 40 C, then it's very difficult. Except you saw in one of the early pictures that picture is actually from Ivanovo, where they had the vertical stacks or vertical pipes from the patient rooms up, and the patient rooms all had radiators. So they used the common hot water. They were able to heat the rooms quite high, and with just that simple vertical stack ventilation, natural ventilation, they achieved close to 6 air changes per hour. And is 6 good? Well, it's better than 0. With some mechanical ventilations, ventilation systems, what happens often is, it's not maintained. A year or 2 down the road, something breaks, then they essentially have a sealed environment with almost 0 air exchange. So anyway, Grigory, I hope I answered that okay.
Thank you, Paul. I see in the chat we have another question about the role of administrative control measures in terms of infection control.
Very, very good question, Zichen. And yeah, I'm sorry you missed it. You'll be able to listen to it from online and also get a copy of the presentation and administrative control measures. And we can't emphasize enough how important it is to have the full system of infection prevention control measures in place. There are lots of administrative controls that need to be done before you even consider ventilation. And based on your risk assessment, you'll determine, okay, what is feasible for me? You know, do I need an environmental control? Do I have a system for maintaining that environmental control? So yes, they're inseparable, administrative controls and environmental controls. Over.
Okay, thank you. I see Daisy raise hands. Is that the old one, or you have another question?
My query is answered.
Okay, good. Thank you. I don't see any hands now, and no any other questions in the chat room.
Hello.
Yes.
Can you hear me now?
Yes, we hear you now.
Yeah, thank you very much. I had problem with the connectivity, but now I'm back. Most of schools in Kenya are boarding schools, so the students board, but the ventilations in the boarding houses are not designed in a way that prevent TB infections. And is there a way WHO can give guidelines to countries just like we do with tobacco control, so that all boarding houses are designed according to what you have already showed us here, so that it becomes part of a WHO guideline specifically for boarding schools?
Okay, let me try to reply. You know, I'm not with WHO, though I've worked closely with WHO. I think if you don't mind developing that comment into an email to the ETTI, and Carrie, feel free to jump in. I think it's an important topic, and I think we could both through Stop TB partnership and through WHO, you know, see if there's enough interest to come out with something for that. Carrie, do you have anything to add?
No, I think it's a really good question, especially in light of COVID, and talk about schools opening up boarding school or university where you'd be dealing with dormitories, or to Daisy's question about academic institutions. So I think it's a very timely question. And I agree with Paul, if you put it into an email, then we can work on getting better feedback to you.
Thank you. I'll do that.
And to everybody, again, I just want to emphasize that you know, if you have specific topics, and maybe this would be a topic for a future webinar as well, to essentially identify, you know, where there is or isn't information for these congregate settings, whether it be an academic setting or you know, a dormitory for a boarding school. You know, we can probably get folks together to come up with some potential solutions, and that might help Stop TB partnership as well as WHO to address it further. Over.
Thank you. So I'm trying to see if we have another question. So no questions in the chat and no hands rising. So if no questions anymore, I would like to thank very much Paul for your great presentation. As usual, I guess nobody can explain better infection control than you. So thanks a lot. And on behalf of Stop TB Partnership, I would like to thank very much the ETTI crew. I don't know, Kerry, would you like to have some closing remarks or anything to add at the end?
Thanks, Viral. No, and I think Paul did a good job, and I'm glad that he posted up the future webinars that were just there on screen. That I hope that those of you that joined today, I've been seeing many of the same names throughout the last several webinars. So I hope that you join us again next week for more on mechanical ventilation, and for the other presentations to follow that. But again, my thanks to the Stop TB Partnership for making all of this possible.
Thank you. Indeed, same day, same time, another webinar. So appreciate very much our collaboration with ETTI, and yeah, the recordings are of the webinars are on Stop TB Partnership website as well as ETTI website. So those who are interested to go back and remember and recheck, please access those. And thank you very much for your interest on our joint webinars, and I wish you a very good day ahead and evening for some of us. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you and bye.